Whoops. All right, so now that I got the record button going, I don't know why my thing at the bottom keeps showing. So I'm sorry. I have clicked off of it. I've tried scrolling down on it. I don't know why it won't disappear. So y'all just have to ignore that. Maybe it'll eventually change over time and it'll go away. But anyway, so the endocrine system and hematologic. So what's going to happen is we're going to talk about a bunch of things in here that everybody probably is dealing with, diabetes, anything like that, that I really would like for you guys to key in. I think after talking with Rob, the more engagement that we had with you guys, I think that has kind of brought a little bit of good key parts to the class. So I want to encourage that. I know that we kind of walking over each other, so I don't really know the best way to handle that to keep everybody from walking over each other as we're trying to talk. But we'll try to work through that. But I really encourage you guys to kind of talk to us, give me some key endpoints, what's going on. Maybe if we talk about diabetes and that you have it, or some other illnesses that we come across in here, just key up and I will. Or if you want to put a little dot in there or something in the chat, let me know that y'all got some info in there. That'd be great. And I just want to make sure that we get everybody addressed. So, but I think this is going to help us all out. All right, so let's get going. Maybe if I click the right button, it'll work. All right. So we know about medicine. That's on every single slide. So we're gonna skip that one. So we're going to go over some of the national components in here. It's going to be diabetes. We're going to do the anatomy, physiology, and pathophysiology about acute diabetics, diabetic emergencies. So we know that that's what part of this chapter is about. Um, we'll talk about sickle cell, some clotting disorders. We'll go into a little bit diabetes, sickle cell. I've dealt with a lot of them. Some of your anemia ones. I haven't really had that many patients in my life, so I don't know if anybody in here is anemic or anything like that for clotting disorders. So hopefully that'll help us out some, and we can learn from you guys. So let's dive off into the introduction. So the endocrine system influences nearly every cell, organ, and body function. Why is that? Because endocrine system endocrine disorders can have many signs and symptoms. So hematologic emergency. I'm sorry, I hear somebody saying something. What? Victoria, you girl, you anemic and diabetic? Well, I mean, I guess you don't check your blood sugar if you got to poke your finger because you bleed out. All right. So I'm just messing with you. I'm sorry. Um. So the reason why we say that the hematologic emergencies, they are difficult to assess. Your actions, if you recognize them early enough, yes, they will save their lives. But at the same time, is you gotta know what you're looking for. Not just because this one class is gonna pick up on teach you on how to do things, or but a lot of just time is gonna teach you what's going on. You'll pick up things throughout your career. I always start yawning when I start teaching. Holy cow. I am sorry. I even got something to drink beside me, so I don't know why I'm yawning. All right. So we'll start here. So the endocrine system is a communication system that controls functions inside the body. So the endocrine glands secrete messengers, hormones. Hormones are chemical substances produced by the gland. They travel through the blood to end organs. They go to tissues or cells that they affect. When it arrives, I'm trying to read something else and it just don't like me. So when they arrive, the messages is received and an action takes place. So it's not like it's our brain that continues to do these things. But so what happens is when the message is sent to, hey finger, move your right finger. It's not an instant thing. It has to travel there, and then all of a sudden your finger starts moving. So that's kind of a little idea. So if the gland is not functioning, it may produce more hormone, so hyposecretions than needed, but it's not enough hormones is to make things change. So you'll notice they may produce it because it's running low. it's running at a quarter tank of fuel, and it needs to operate profusely at 3/4 tank of fuel. Well, it may dump off a message in there and say, hey, increase this. So now you're going to get some hyperexcretions, and then it's going to run about half a tank and start filling itself up. So I hope that kind of breaks it down to you and understand what I was trying to say there. All right, so glucose. I'm sure everybody knows about glucose. It's our energy source. Um, it is. It's how we function. It's how we make it. No matter what happens, that's what rolls. So glucose metabolism. It's the brain needs two things to function, and it's glucose and oxygen. If it don't have that, it ain't gonna work, no matter what. Now you need blood in there, but you gotta have glucose, which is the energy, and oxygen the function. Sorry, I'm watching my kid wander through the kitchen like he's. What do you look for? I'm sorry, I don't know. So, all right. So insulin is necessary for glucose to enter cells, and without enough insulin, the cells do not get fed. Well, I'm a big boy. I like to eat. So if there's not insulin in there, we ain't gonna get food. So we need to make sure that there's enough in there. And if there's not, that's where we start to get put on medications because we become hypoglycemic or hyper, and we got to get these things function out, right? So this is the beginning process. All right. So the pancreas produces and stores two hormones, glucagon and insulin. Those are very, very important. Glucagon and insulin is produced by the pancreas. I'm sorry, produces and stores, yes. All right. So isolates of the Langerhans are found in smaller portions of the pancreas. With the isolates are alpha and the beta cells. Alpha cells produce glucagon. Right here, y'all look at my cursor. Write this down. Highlight it in your book. Remember that. Alpha cells produce glucagon and beta cells produce insulin. That is a very good question. You might see that posted on Facebook later. I'm just saying, I don't know. That was a good question of mine. But maybe a fill in the blank since a lot of y'all participated. And I want to say thank y'all. So the pancreas stores and secretes insulin and glucose in response to the level of glucose in the blood. So our body constantly checks it. Like Victoria, I'm sorry, I'm gonna pick on you for a second. She says she checks hers daily. Well, in this case, the pancreas checks it all the time. So if it needs more, it produces more. If it doesn't need more, it slows down. So if you ate 4 cupcakes and they're like, whoa, our sugar don't need to be 400. We're gonna not produce none for a little bit, and our body will work it and use it and run it off. So that's kind of the process behind it. That's how they work. All right. So diabetes mellitus is a disorder of glucose metabolism, such as the body has an impaired ability to get glucose into the cells to be used for energy. It affects about 9.3% of the population, which I personally, Chris Wally, feels that number is low. I feel that we have more than 9.3 people to have diabetes. Or it may just be, they control it by diet. I don't know, but that's just my personal opinion. Without treatment, the blood glucose levels become too high. Travis, I agree. We have that number just in my family. I don't know, man. I don't know how old this. Well, this says was at the bottom. Jones and Bartlett 2017. So that's what. Let's just say 3 years old. It's too far. It's too early in this year to make it 4 years. So I mean, in 3 years, I believe that the number can change. Of course, things change as soon as they produce it. It's already old. It's like a new car. As soon as it rolls off, it's already old and out of date. So I'll give you that one. Victoria says, "I wish they could do a pink." Well, they just don't, have. I mean, you can probably find one on the black market if you need a new pancreas. Just I don't know who you're gonna use to put it in, but be careful. It could be like a hyenas or something. All right, back to mine. Figure out where I'm at now. So without treatment, blood glucose levels become high. In severe cases, they may cause life-threatening illnesses or coma and death. If it's not managed well, it can have severe complications. Now, these are the worst, okay? So when I read these to you, it's not like Some of y'all know you're not going to automatically have this. So you may be blind, you may go to cardiovascular disease or kidney failure. Kidney failure, yes, we know that that can take place, but that's on the worst case, like screw it, I'm not treating nothing. And they just gonna let things function. All right. So treatment for diabetes, medications and injection of hormones that lower blood glucose levels. Oh, I'm sorry, I forgot something else. So before I type this, how many types of diabetes is there? I expect 9 answers. I can say I expect. I hope to see 9 answers. How many types of diabetes are there? All right. So yes, I'm gonna tell y'all I completely agree with y'all. But but there is three. So we have diabetes type 1 and 2, which that's what y'all named. And then they're actually calling pregnancy induced gestational diabetes as a third one. So that's where they're saying it is that they may not be a diabetic after being pregnated, or they may keep it. So that is the three. So that to me again sounds like a good question too. Is there are three types of diabetes and pre-diabetes? That's correct. So with that being said, is that they may, you know, be a diabetic, they may not be a diabetic. So just think about that for those three types. All right. So we talked about this treatment for diabetes. I gotta get my marker. Oh, sorry. All right. So medications and injections. If administered correctly or incorrectly, it'll work. So if they do it right, it works. Well, if they don't do it right, it's not gonna work. So that's the reason why we harp on these people that we go see all the time. Fred, when's the last time you took your diabetes medicine? Why is there 9 vials in there and they none been used? Fred, we got to work on this. So y'all know what I'm talking about. Y'all have all seen it. Either y'all have done it too, but you're like, oops, I forgot. Supposed to take 2 summits. Yeah, then those are common. The 2 shots in the stomach. Those are now starting to be the common ones. My dad was a diabetic for a while, and finally he got his stuff situated and dropped a ton of weight and looks amazing. And I think I took about half of the weight he got. So, oh, oh, when she remembers, there's the truth that she took the shots. All right, um, so low blood glucose level is called hypoglycemia. That's important, y'all. So remember that it's the hypo. High blood sugar is hyper. If it's unrecognized and treated, it can be life-threatening. We know that. We deal with these daily. We know people that's got that. So I'm preaching to the choir. But so you need to know the signs. So they can basically be the same. You can have some of the same symptoms with high and low, and I don't know if it says this, but I'm sure you guys know. But remember the fruity smell that you may smell from their breath. Now, I know that it's very hard to smell that with these wonderful masks that we have on. If you've not smelt it, it produces the smell of a alcoholic beverage. So remember, it's not just your DUI stop that you're going to check a subject out. They want to make sure that it's not a diabetic, and you check their sugar repeatedly. Don't just say, "Oh, well, I know this guy. He's not diabetic. He's just a drunk." That's not the case. Go ahead and check it because that's negligence because you didn't check it when you knew you should have. So, right, Victoria, it's kind of like a juicy like a fruit gum. Now with these masks, if I smell it through the mask, we're gonna all have problems because that means they breathe in their breath on me. So let's not do that. But know your signs. High blood sugar is hyper. We just talked about that. Can result in death or in a coma. If treatment exceeds a patient's need, it can cause life-threatening state of hypoglycemia, low blood glucose level. Hyper and hypo can occur in both diabetes of type 1 and type 2. So that's very important. You will encounter many patients displaying the signs and symptoms of high and low blood sugar. Hyper and hypo can be quite similar and presentation. That is very, very correct. And you only going to know when you poke that little finger. Now, yes, you can check their blood glucose level off of an IV stick that your advanced and or paramedic does. But if you don't know how to do it, it's okay. Just poke their finger because some agencies don't allow that. You have to get it from a finger reading, and you can't get it from a venous stick. So just know your protocols of where you're at and what's going to be the best beneficial. And all the time, if you just don't know, ask. Hey, I'm not real sure how to do this. Can you show me? All right. So hypoglycemia can develop if a person takes his or her medications but fails to eat enough food. It is important, but you don't want to overeat. You want to just take your medication, eat enough, and be good. Let's ration this out. If a person takes too much medication, resulting in low blood glucose levels, normal dietary intake is ignored. So if they take too much medication because they're gonna be like, oh, well, I'm not gonna eat, and da, da, da. Well, then they eat too, and now they tripled. So now they're hyper, and they just trying to stay around normal. Hypo um, Hypoglycemic patients require immediate treatment. You can't let them sit around. You have to treat them on the quickness. Victoria says, I just want to point out when you poke their fingers, please do not shove it so hard into the finger. We check it every day, and when they shove deep bruises, your finger hurts. Almost was what she said. I'm gonna let her say that because that's her thing. I don't have to check mine. I'd rather get an IV than my finger poked, just to be honest. Um, so if they're low, remember it's saying right here in the books that it says oral glucose if the patient is alert enough. I'm not a huge oral glucose person. I would just rather, start an IV on them to where I can give them their D50. Or if you carry glucagon and you're on a medic unit or an ALS unit with an advanced, you can do glucagon, which the glucagon is just as easy. But with at least with the D50, and the reason why I like D50 so much is because I can control it. I can give it in stages and not a sugar dump at one time. Because if you sugar dump them, what's it really doing for you? Not a damn thing. Because all you're trying to do then is just overload their body. Well, that's not working nothing. So remember that. Just that's a personal thing that you need to take in advance or take in consideration when you get out there and you have the ability to do that once you go to advanced school. I hope y'all realize how I just threw that in there when y'all go to advanced school. Um, oh, and just FYI, we've just had a big instructor meeting. My brain works in little bitty ways, so I hear these little things go off and I have to talk about it. We've got some really, really good news about to roll out for our future classes. We've been working on some things. We're moving forward with a bunch of things, and we're so excited that during our instructor meeting the other day that these new ARES add-ons are going to be super, super helpful to everybody, and students included, instructors included. So I know Rob's going to push that out soon to you to let y'all know what's coming and what has just happened and taken place. But we are pretty stoked about that as an instructor board, or however you want to call us. So just remember that. You'll see it soon. All right. So autoimmune disorders is where the immune system produces antibodies against pancreatic beta cells. Now, I I know several people that's got autoimmune disease. My mom had it. My mom had Crohn's disease, autoimmune, cancer. I mean, I'm gonna tell you later on. Y'all probably hear me say, "Oh, my mama had that." My mom wasn't super super sick, but she did have a lot of things. So that being the case, so autoimmune disease is. I always say that, like, oh, look, there's a rash on you. Huh. People don't know why. People just barely got them. I mean, anything can trigger their autoimmune, and it can just happen out of the blue, not just because of one particular thing. It can just be out of the blue and go from there and start from now on that they have it. As you see, it's caused by the missing of the pancreatic hormones and insulin. Without insulin, glucose cannot enter the cells, and the cells cannot produce energy. So it's kind of important for that. Uh, I don't really know where I was going with that thought. We're just gonna skip it then. All right, so let's break down diabetes here. Type 1 for sure. Onset usually happens from early childhood through the fourth decade of life. Um, I know several people has got it. They got it late in age, they got it early in life, they dealt with it their entire life. I know several people on pumps, several people in EMS that are on pumps, and they do just fine. So once they get it going, they get everything situated, and they need that. Give me 1 second, folks. My kid walked in, and I'm single parenting tonight. My wife's out and about, so give me 1 second. All right, sorry about that. Now I'm back now. All right, so the immune system destroys the ability of the pancreas to produce insulin. So now, since it's destroyed, we gotta work it. We gotta get things working. So now they realize, well, certain things start happening. You start crashing so many times, and then be like, well, we need to fix this. So that's where the whole process begins. As the patient must obtain insulin from an external source. So now they start on shots. Patients with diabetes type 1 cannot survive without insulin, so it is a fatal process. Everybody knows that. Y'all dealt with that. Y'all know what's up. Y'all dealt with it or deal with it daily. Patients who inject insulin often need to check blood glucose levels up to 6 times or more a day. Oh, Jesus. I don't want to poke myself that long. I'd rather have that little thing that I can rub my app on, and it just pops up. The little button in your arm, I'd be perfectly fine with that in my book. Just saying. I checked mine 3 times. All right. I'm just making sure the slides on my end look the same. I'm just making sure they changed. All right. Many people with type 1 have implanted insulin pumps, which is not a big deal no more. It's super easy. Unplug them, plug them up, change the batteries, put new insulin in. Functions like a portable pancreas. It's not like they used to be, I can promise you. All right. It will continuously measure glucose levels and provides insulin in the correction doses of insulin based on the carbohydrate intake. Bruh. I promise y'all I'm not drinking. I'm just drinking straight soda, and that's it. All right. It limits the numbers of times the patient have to check their fingers. So with a lot of the machines I've seen, they constantly monitor it, and they'll only beep when either they're injecting or it's time for you need to do something and look at your machine. They handle their cells. Travis says my niece got her pump a month ago and it has dropped her A1C from 12 to. Jeez, that's awesome. So yeah, it's portable. I'm not sure how old your niece is, but let's just say she's young. So if as a young kid gets that functioning and they understand it, like, okay, with even 8, man, that's amazing. They can deal everything they want to do, and all they gotta do is wear this pump. Um, I've seen kids on basketball have the pump on them. Football is a little different. They may have to take it off while they're out there, come back in, plug it in, check it, then they can go back out. But it gets them back to normalcy. They may not know what normalcy was, but they're like, ooh, I can be a person now. So sometimes they do take a little offense to be like, oh, they gotta wear a pump. Well, people ain't nice. Even the grown-ups aren't nice, so forget them. Um, let's say so they do malfunction. These machines are machines. They do screw up. So at the same time is we got to make sure that you take care of things when you see them. So if you notice things are continuously to start going south, that they do need to check their fingers, and they may say, "Hey, check your finger once a month with the pump." And I don't know, but that's just something that you can backtrack on and check from there. Is because these things are machines. So they always inquire about the presence of an insulin pump, ask if it's working properly. So anytime you go to these diabetic calls and ask them, do you have a pump? Because if you see the little, I call them plug-in ports, but that's really what they are. It's just a machine just plugs in. It's just an imported port that's been put on them. So most of the time it's on their stomach, on their side, or somewhere like that out of the way. That it's working. If you maintain the batteries, everything seems right. Why is your sugar high if your pump's working? So again, these pumps, they are man-made. So anything that's man-made can mess up. Not saying the pumps are a piece of craps, but that's just the way it works. Type 1 diabetes, most common diabetes of childhood. A patient with a new onset with type 1 will have symptoms related to eating, drinking. Pyluria can take place, polydipsia, polyphagia, weight loss, and fatigue. There's a lot of poly there. So I think it talks about that. When a patient's blood sugar level is above the normal, the kidney filters system becomes overwhelmed and the glucose. So when they basically pee it out, so their tank is full. So if we got them bumped up to full on D50, well now that their body's functioning and everything's working, their body's going to try to start functioning that again. Well, it ain't got nowhere to go. So it's going to start peeing it out. Well, once they pee it out and they start dropping down, it's not going to function like it should. The pancreas is going to function like it should to get the insulin levels up. Again, that's why I like my D50. It's because I can bump it up as I need it. I'll give them a bolus of 50 initially, or half of it to be honest, and then the next I give it in 25 stages. So to give the full amp, I do 50, 25, and 25. So that gives me my 100 of the amp that's gone. So that's just a personal thing. I learned that from an old friend of mine, and he explained to me why, and I just got it. And that's the same thing I did to y'all. It's just you don't want to dump them. You want to hit them with some, let everything start functioning, and realize and be like, damn, I ain't been working. I need to start working. So it's got room, and you don't have to give the full amp of it as an ALS provider. You can just give them that what they need, but you've got it available. That's why I like to give it versus the oral glucose. All right. So we're going to talk about when glucose is unavailable. What's going to happen? What are we going to do? So the body burns fat rather than glucose as it produces acid waste. And that's where you get your ketones. So ketones, as we go further, you'll learn about that. As ketone levels go up in the blood, they spill into the urine. Kidneys become saturated with glucose and ketones and cannot maintain acid-base balance in the body. So that's the reason why your diabetics also have to, when they go to the doctor, they're always peeing. They always got to pee in a cup. And they don't care. They're not testing you. Let me say they do care, but they're not testing you to see if you're on drugs. They're testing your urine to see if it's sugary or if it's an acid. Does that make sense? I hope you'll kind of get what I mean by there. Uh, the patient breathes faster and deeper as the body attempts to reduce the level of acid by releasing more carbon dioxide through the lungs. So that's a way of burning it off because that's a muscle. They're using the muscles, so they're burning that off. Well, when you hear that and you see that in their sugar, oh, well, look, y'all get told right there. It's called Kussmaul respirations. Once you see these respirations and you recognize them as being Kussmaul, you know what the body's doing. It's a dump. They're dumping the urine. I mean the oh come on, I just went blank. They're dumping the pro. I mean the glucose out. So it's got to go. The body can't handle it anymore. I don't know what's going on, but it ain't you ain't staying here is what the body's saying. So they got to burn it out. They got to work those muscles that will burn the most amount of sugar, and you see right there, it's through the lungs and all that. So they start breathing faster. Type 1 also is a fat metabolism and ketone production. A life-threatening illness caused diabetic ketoacidosis, DKA. DKA may present as generalized illnesses, but can also be you can see abdominal pain, body aches, nausea, vomiting, and an altered mental status if severe enough. So you gonna see these on a lot of your patients. You see my mouse keeps going in circles for reasons. You're gonna see these on a lot of your hypos until when the body says nope and it shuts down and they faint, they pass out, they go to sleep, and by God, to hope to goodness that they're found prior to the body just saying bye bye because there's nothing there. I've taken care of a guy with his sugar as low as 4 and was able to get him back. He's never been that low before. And some EMS providers, their machine goes up to 500. I've taken care of one that his sugar was well into the 1500s, and he was put in a hospital. Obviously, I didn't fix that in the field. I ain't that good, but on different spectrums, and both of them acted the same exact way. Would have never known unless I'd have checked the sugar. The dude with 4 was the most fighting son of a gun that I've ever had in my life. So I deal with all these except unconsciousness. Highest mine's ever gotten was 804. And that's and people that sometimes they realize these and they realize that their sugar's getting out of whack and they're able to catch it. Some don't if they don't get it real good before they go to bed. That's where they'll bottom out. And sometimes they're found unresponsive in the morning because of that. Or DKA sets in and there's a whole other kind of worse. All right. So if DKA is not recognized, it can be fatal, 100%. When a patient has DKA or altered mental status, ask family or friends about the patient's history and presentation. Build your information. That's your first general impression. Build your report. So you always want to. Oh, I am so sorry. You always want to stick them in the finger. Get a glucose monitor. Get a glucose reading. Most of the times with DKA, you're going to see higher than 400. And DKA is something that can be slowed down in the field, but ultimately it's going to have to be taken care of in a medical facility for it to get handled anything higher than that. It's not something that should scare you, but at the same time it's something that needs to take urgency and they need to go to the most appropriate facility. Sometimes your local Band-Aid station, and everybody's got one you know about, isn't the best one for it, but due to the wonderful world that we're in right now, they may be the lucky drawer of that card. And they may get to treat that patient and or they can send that patient out later on. Type 2, so caused by resistance to the effects of insulin at the cellular level. There's an association between obesity and increased resistance to the effects of insulin. We've seen that over time. We've noted more and more studies of it. There's an association. Pancreas produces more of insulin to make up for the increased levels of blood glucose and dysfunction of cellular insulin receptors. So there it is. The body's automatically doing some of these things on their own and producing this. The blood glucose continue to rise and do not respond with the pancreas secretions insulin. A process called insulin resistance. Insulin resistance can sometimes be improved by exercise and dietary modification. So a lot of times your doctor will tell you to start exercising and watch what you eat. Not should you say, well, I exercise when I get up out of the chair to go to the refrigerator and I'm watching the food that goes in my body. No, that's what got you to this point. But the thing is just certain things you can cut out on. Just it being little. It's not, you don't have to make a drastic change, but some little things can be changed and you can rock on. Get your weight and everything under control. You may not be a type 2 no more. Some oral medications can treat diabetes. Some increase secretions of the insulin and pose a high risk of hypoglycemic. Some stimulant receptors for insulin. Victoria, yep, my doc just told me that I'm insulin resistant and I want to keep and started exercising. Now my meds are working. See, great. Just a little bit of, and I don't mean this ugly by no means, Victoria, but just a little bit of effort on all of our parts could help us all out. And just if you can do that, maybe somebody else in the house can do anything with you, and that keeps them from happening. Somebody else on the street sees you doing that, and they've noticed a change in you and in your family or your outlook on things. They may turn around and start doing it too. So just that little bit of motivation. Injectable medications and insulin known for type 2, we've all seen that. Just because they get in injections doesn't mean that it's always a type 1. Could be a type 2 on the worst case scenario, or it's a worst case late found of diabetes. Often diagnosed at the yearly medical examination because we don't really know. It just things progressively get worse. They progressively over time start right there. Changing vision. You're like, man, I've noticed this whole year I just can't see nothing, even though after you'll go to the eye doctor more than you'll go to the regular doctor because you want to be able to see things. If you notice this person keeps on getting infections, it's not around the same area. Could be respiratory. It could be joint related. It could be anywhere. Some of your telltales is numbness to the feet. One of the guys I work with offshore, older guy, good guy, love him to death, super good. He's just can't feel from about calf down. His toes are in good working shape, but he just can't feel them. Yes, he's still offshore. I don't know how. I didn't ask those questions, but he's actually a pretty good dude. All right, so Schumer, symptomatic hypoglycemia occurs when the blood glucose levels are too high. Let's see. Occurs when blood glucose levels are too high. The patient is in a state of altered mental status resulting from several combined problems. All right. In type 1 diabetes leads to ketoacidosis with dehydration from excessive urination because they just pee and everything out. Got to go somewhere. And type 2 leads to ketonic hypermolarism state of dehydration due to the discharge of fluid from the body system and eventually out through the kidneys. So it's still pushing it out. It's still pushing it somewhere or the other. It's just on what process that it takes and how long. It could be a fast process in type 1, and type 2 is going to be a little bit slower because it's filtered, pushes it from the pleural space all the way out to the kidneys and all that other stuff. So it's going to take a hot minute for it to get there in type 2. If an individual is hyperglycemia for a protracted long of time, consequences. I'm so sorry, my daughter's just decides to throw a fit in here. Some wounds that do not heal, you'll notice that they're constantly open. You'll notice the redness around them. They start inflammation, numbness to the hands and feet, blindness, renal failure. These are kind of in the worst bases. And gastric mortality problems, you'll notice that the renal failures at the end and blindness are your worst. The numbness in feet is just because it's been there forever, and it's basically that area, the feeling, the whole tissues of the hands and feet are dying. Wounds, they will heal. It just takes forever, and it takes them a long time, if at all, to heal any on a wound that's happened. And anything, bump. My grandfather was not that bad, but he just wouldn't heal anytime, and it was due to an infection that happened back in the days when he was in high school. All right, so when blood glucose levels are not controlled in type 2 diabetes, you have your hypermolar hyperglycemic non-chaotic syndrome. Holy moly. We're going to call it HHNS from now on. Key signs of the HHNS include hyperglycemia, altered mental status, drowsiness, lethargy, severe dehydration, thirst, dark urine. And when they mean dark urine, they mean like dark, like It's not Coke dark, but it's like a dark sweet tea. Does that make sense to you guys? Like it's an apple juice with a little bit darker. Um, in here also they can have seizures, muscle weakness. It's kind of they really both of them type 1, type 2. They all ultimately have the same signs and symptoms and the same end. Obviously, we all know what the end is unfortunately is death, stage 4s. But oh, Travis, you got me on the HHNS. So it is hypercholesterolemia, hyperglycemic non-chaotic syndrome, HHNS. That's a tongue twister right there. Symptomatic hypoglycemia, hyperglucose levels in the blood. Glucose is the excretion of the blood in the urine. Patients do respond by increasing their oral intake, which causes pyluria, that means they're going to pee a lot. So if you can increase their fluids, it's going to help because they're going to pee it out because they're constantly having to pee. You know, I tried for a long time, worked out real well. Drink a gallon of water a day does helps control your blood glucose also, but it's you pee a lot. So with that being the case, they're peeing the excess out, so it will help to increase their intake. In HHNS, the patient cannot drink enough fluids to keep up with the exceedingly high glucose levels in the blood. So no matter what they do, it's there. It's they ain't gonna get rid of it. And they're gonna permanently have dark urine. It's gonna have a odor, very nasty odor to it. You may see some. I don't know how to put that. I don't know how to put it, so I'll just wait. So the patient may become unconscious for having a seizure due to severe dehydration. It's just because you're out of luck. They can't get enough. Now it's not going to say that it's going to instant shrivel up and die. No, but throughout time, throughout anything like that, it's going to take forever for them, if at all, to get enough water in them. No matter what they do, they can drink 10 gallons a day. It's not going to keep up with it. Acute emergencies with the patients of blood glucose. So I'm not going to sit there and we're not going to go over that. Y'all tell me, what are some of the emergencies that we're going to come across for insulin? Either it's going to be too high or too low. What's some of the things that's going to happen? What are we? One is what we might see. Two is what the call is going to be for. Y'all tell me. Before this medicine, Victoria is saying it felt like I was chewing cotton every day. Lost its consciousness is correct. Cotton mouth is, I think, where we're going with that, because no matter what, you're thirsty, you're dehydrated. We may get it for a seizure. So I always say that every every patient that we go to, every call that we go on, no matter what, should have a glucose to them. It doesn't matter if it's a slip, trip, and fall for ice on the ground. Check their sugar. There's a reason why 90% of the report systems always ask for a CBG. Well, if it asks for it, or it's a mandatory, don't you think it's probably important after about 10 times? That's why. Because if it's important and they ask for it, then it's going to be super important that you get that information. So they wouldn't put it in there if it wasn't important. And let's go back here. So Robin's saying thirsty and always tired. Victoria may think they are drunk. If it's too low, they can get violent. Well, and Victoria, I've also seen hyper ones get very feisty too. So it's not just low ones. The old ones, the high ones get feisty too. And be prepared. Just all I can say. Hang on to that. So in being tired, I mean thirsty, and just can't get like, I mean, I can tell you mine. I had that things. I was like, man, I just can't get enough sleep. I'm always tired. So I was like, I literally, when I went to the doctor, I was like, Doc, I think I'm pre-diabetic. She was like, No, you're not. I was like, let me tell you why. I'm always thirsty. I can't sleep. I sleep like maybe 2, 3 hours at a time. I was just like Debbie Downer. That's what I felt like. But guess what? I just have sleep apnea. Man, I tell you what, that has fixed me. Well, and my testosterone's superly low. So those two things getting fixed, I mean, it's like there is a ray of energy. Obviously, besides when I start teaching here, I start yawning. But they checked my sugar when I got there. They checked it again. I had to check it for a couple of times just because of the situations. But I mean, it's you should check it no matter what. Just make sure that things are being checked out. Hold on one second. Single parent time. All right. How to do a single parent teaching moment. Not a single parent. My wife's at work, so I don't think nothing's going on. All right. So some of the common reasons for low blood sugar is the correct dose of insulin without change of routine. The patient exercised more. They ate more at later time. They maybe have skipped a meal. There's several different reasons why it could be that way. Not just saying that they're always gonna have this hypo. They just may not have planned correctly. Uh, that's my husband. He hates to check it, and I would see. Yeah, yeah, I know. So make sure you get the correct dose of insulin without the patient eating and stuff in the sufficient amount, because if they overeat, it can mess up their medications. And if they're on a pump, the pump can automatically do it, but if it's one of those that they're doing themselves and it's pump it's they eat too much, they need to check it on a regular basis. Now, you don't want to check it right after you finish eating, but a couple of minutes after you eat, maybe 10 minutes, 15 minutes at the max, check your sugar, and you're going to have to be on that floating scale to make sure that you have enough insulin. Um, Correct dose of insulin, and the patient develops an acute illness. So that's the same time as is it they constantly will check it for a hot minute until they know what your dose is. Um, it may take them 6, 8 months to get everything situated. They may not. It may take them a little bit longer to get everything situated out. So keep that in mind. Just because things are going on and they're working on that doesn't mean it's going to work out easy. All right, so hypoglycemia develops much more quickly than hyper. In some instances, it can occur in a matter of minutes. And 90% of the time, and I know this may be sound ugly, but it's always going to be as you're getting ready for bed, or as you as an EMS provider are sleeping good and comfortable in the chair, and it happens. Because I had that happen to me the other night. I mistakenly, in a pity moment, felt bad for somebody that our local ambulance service that I'm part time at, and I went in and worked for. Horrible, horrible idea. Let me say that again. It was a horrible idea. I ran. They didn't run but one call in their first 12 hours. We ran 7 calls as soon as I walked in the door till 7 in the morning. And the one at 4:15 when I was sleeping so comfortably in my chair was because her sugar was low and her husband woke up to go to work and he went reached over to give her a kiss and she didn't respond like she normally does. He was like, we were up at midnight. Like I remember her seeing her check her sugar at midnight. So there's your point. At the same time as it may happen pretty quick, and that's a pretty quick time for hypoglycemia when they checked it and everything was good at midnight. Some of your signs and symptoms. Do y'all have any other signs and symptoms that affects y'all than what y'all are seeing right there? Uh, we know the respirations because it may not be producing enough energy for them to breathe normal, or if the rapid one is because they're going in DKA. So, is there anything on there that y'all see that y'all deal with any differently besides the normal to shallow respirations, pale moist skin, diaphoresis, dizziness, headaches, rapid pulse, normal. True, Travis. Maybe I need to hold up on yours. Yours is weight loss. Victoria, yeah, I've heard this, Victoria, the shakiness, and I guess I'm not gonna say that's muscle fatigue, but is it? You think it's because you don't have enough energy for your muscles to function, and they're starting to shunt out on things, or what's that exactly? So, and that's what I was wondering. Is it's just to see if that may be like, I call it like the workout syndrome, that since your body's worked out so much you can't even like pick your cup up to drink a glass of water. When mine would bottom out, I could eat and the shake stop. And yeah, and that's the reason why I'm like, if you can ever get a sugar out in the field and you're able to do D50 and you get the sugar up, you want to make sure to tell family before you leave is they must eat a meal before I can leave. They need to eat, because if they don't eat, we're going to be taking them to the hospital. So let's do you, me, and them a favor and get them some food in their bellies. Because they put food in their bellies, it's going to stop them. It's going to, I mean, it's going to heal. It's not going to heal them, but it'll stop them from us having to come back. I always tell them, this is my telltale sign too of Wallyism. First one's on you, second one's on me, and there ain't a third time. So guess what? First time you can sign this refusal, but if I come back here, you will and must go. Do you understand what I'm saying? And I look at the family too. Family understands that, and I'm like, all right, so y'all tell me what I just said. So what you're doing is you're just verbalizing it, and you're getting some confirmatory that they understood what you mean by that. Victoria, maybe I need to get checked out. Hello, I've lost like 16 pounds in about 3 months, and I'm already little. Nicole says I have all the symptoms. Thought I was thyroid. Hey, you know, Nicole, you may want to check on that too, because your thyroids and your sugars could be causing that. Um, I did not sleep at a Motel 8, and I am not a physician, but those two combined can cause some weight loss. So that could be your issues too. And it could be going to see your regular doctor, and maybe not have to go to a specialist or anything like that. All right, there you go. You just answer your own question, Nicole. Victoria says scrambled eggs and peanut butter, toast, and orange juice with. Well, let's like see. This is the reason why I want y'all to talk. This is the reason why I was hoping y'all could talk through this class. I think it's making it easier. Y'all are kind of teaching yourselves and teaching us and the group um, on things. So that's really important to me. Um, Signs and symptoms. We talked about that already. Y'all have brought up some things there, so we'll skip that one. Hypoglycemia is quickly reversed by giving the patient uh, glucose. Without glucose, the patient can sustain permanent brain damage. Huh. Maybe we can identify that. What's wrong with some of these people? Maybe they had high blood sugar for a long time. What was that, Victoria? Like 859? Was that what you said? No, I'm just messing y'all. I hope y'all remember that. I know Victoria pretty well. Um, so you see the chart here, what it breaks down to. Here's our normal. We should range in this normal range, anywhere between 80 and 120. Some doctors like to see this number versus that. Now, that's just normal, okay? Hypos, you go further down. Obviously, anything below 40 um, is going to cause major issues. So that's where you're going to get here. You may not get a call initially, but sometimes down here, because they're going to give off that appearance of things are wrong, or they're just super sluggish, or hey, look, something's up. Then you come over here into hyperglycemia. Some people function very well in this line. Just because they are hyper doesn't mean they're not going to function. So when we get higher in here, hopefully by that time it's been recognized or called. If you see it higher than 400, you want to kind of consider DKA, but at the same time, look at the signs and symptoms. Do they have that panty breathing? Or are they trying to pan it off? Or they're breathing heavily? Or Kussmaul's respirations? So that could be a thing in there. Wow. What time is it? Let's take 10 minutes. It's about that time. I will see y'all at 5 after. I gotta go there. I gotta get up and move around too, my legs, and I'll see y'all at 5 after 7. See y'all in a minute. All right, all right. I know y'all missed me, so it's all right. Um, so the scene safety. Hold on, I want to look at something real quick. If it's, I should have done this on break, but it didn't let me. I didn't think about it. All right, we're good. Now I gotta figure out where I'm at. There we go. All right, so we're gonna do scene safety. Everybody knows about that. We talked about that. We're gonna try to add something a little different. So patients with diabetes may use syringes. Be very careful. Sometimes you have some sloppy people that are diabetics. Um, some of your telltale signs are Coke bottles, 2 liter bottles full of syringes, um, your red boxes that are around the house, um, and that's some of your telltale signs. Like I said, I like to go to people's refrigerators and look in their pantries and their refrigerators and their little butter churn or little butter box to see exactly what is if there's anything in there. Depending on the area of the house or how the house looks, I'll always check it. Give me 1 second. Sorry, I had to give that fatherly love there for a second. So question to bystanders, family. They may be a diabetic, but the problems that it is that they may not be a functioning diabetic because they don't have the money for their medicines. They may not have the medicines on hand because they ran out, or because maybe that their vision has been bad and they've upped their medication not knowingly because of that reason. Um, Keep an eye open for the possibilities that trauma may have occurred. We always know that. So, um, if you happen to see some insulin bottles or plates of food or glasses of orange juice, that may give you that telltale sign, like Victoria pointed out earlier. Keep open possibilities. Determine the mechanism of injuries. Depends on what happens. Kind of give you a telltale sign of what's leading up or why you're there. Um, get your general impression. I've told you from the get go. Once you get that general impression, go with it, stick with it, live it, love it, and it can be changed. Um, so the airway problems, if the patient is not breathing on a normal status where they're breathing enough for themselves, give them oxygen. Give them some new. It's cheap. It's easy. I've told y'all that. Give them oxygen. Roll with it. Rock on, and everything can be good to go. Um, if they're if they're hypo, uh, if they're if their O2 stats are below 92% or 94, right there is what it's telling you. Give them oxygen. If they're if their restlessness, they may be anxious or anything like that, you know that they may be their O2 sats may be super low. So that's another telltale sign. We tell you how to look for the ones that they tell you. Um, when you're talking to your patients, you want to determine their APU scale. Are they alert, painful, unresponsive, all these things? They alert to verbal statusness. They can answer me. Um, while we're here, we're going to check our CBG also, check for your cervical spine injuries. If you're arriving, Mickey saying, if you're arriving saying and it's not at home, look for a small cooler. Yeah, exactly. Point proven. Look for that little what we saying like the little igloo coolers, the little tote around ones. That's one telltale signs too. Patient shows sign of inadequate breathing, a pulse. Uh, Pulse ox may be lower than 94, altered mental status, and you should give them 15 liters of oxygen. They need it. It's easy. That should be your first go-to telltale tool to use. Your primary assessments use airway and breathing. Hypoglycemic patients may have Kushmal respirations, and if that's the case, like we talked about the sweaty, the fruity breath, that that may be hard to do now. Okay, if the since the mask and all that, so just keep that in mind. Somebody may tell you that this person's that way. Um, hey, can y'all still hear me? I'm just trying to make sure something's working. I had to turn my a beeper off on my computer. All right, good. Hypoglycemic patients will have normal or shallow rapid respirations. Continue to monitor your respirations throughout patient care because they can change, they can get worse, they can improve. Anytime that anything of that happens, document it. If something changes, it comes up, change it up. If you need to increase it or decrease your O2, that's okay. Circulation, you always want to check for dry, moist, pale skin, warm skin, any of those. So, as you can see right there, dry or warm skin can be found in hyperglycemia. Moist, pale skin can be found in hypoglycemia. Not all the case times that you just because you find that will be the cause of it, but those are some of your ones that you can tell. Rapid weak pulse, spontaneous symptomatic hypoglycemia. So it could be man, my train of thought literally just went poof. Victoria, that was about earlier. Am I ready? Yes, but am I functioning? No. So we know about our transport decision. Load and go, stay and play. I don't really know what else we need to say right there on that, but that's kind of the ones that we need to stick with. Is it load and go, or we're gonna get to stay and play? So if we have to sit there, if we can get information from the patient, prime example. So I hate to say war stories, but so the night I also had a seizure. Sweet young lady, second time she's ever had a seizure in her life. Slipped, tripped, and fell. She woke up to 4 firemen, 2 EMS people in her living room, and she or in her bedroom at 4 o'clock in the morning. Or it's 5:15 for this one. And they're like, she's like, who in the hell y'all? She was still out of it, but she was okay enough to be able to answer some questions. So she was wanting to go back to sleep, but she was very interested to figure out who these people were in my room, but she was going back to sleep. So finally, when she came around, super nice. Initially, she was a little combative, got that handled, got that under control. But you got to give these people some time, let them adapt and learn and function to make sure things are okay because they don't know what's going on. So if the patient's that way, just work with them, give them some time. Responsive diabetics often will know what's wrong. They can tell you, I'm a diabetic. If not, go on for there. If a patient is eating but not taking insulin, hyperglycemia is more likely because now that they ate too much and either they haven't given their shot to try to balance it out. So they fight that winning losing battle is what I kind of call it because they want to do this, but they don't want to be a diabetic. They want to eat them sweets, but so that's the battle that we fight in EMS. Is a patient's taking their insulin but not eating? So hypo, and the reason why is because it's not sustaining. So if they give the medication, that's cool, but it's not there to sustain. It's not going to last. It's not going to stay. So just because they gave their shot, by the time, let's say they gave grandma the shot and she said, oh yeah, I'm going to eat in just a minute. Y'all go ahead and go. Well, she doesn't eat. Well, an hour later, they can't get her on the phone, and now we're there because of that reason. So carefully observe signs and symptoms, determine whether they're hypo or hyper. That can tell you your active treatment. And that's why I always say, give everybody you come across a CBG, finger poke. It's the easiest thing to tell you what to do. And it's always going to be in the better idea. Yeah, hey, look, I just want my CBG machine said it was done this, this, and this. That's why I did that. So on your sample history, you're going to ask certain questions related to a diabetic. Here they have them. Did you take your insulin or pills to lower your blood sugar? Do you wear an insulin pump? Is it working properly? Have you taken your insulin dose or pills today? Sometimes they may have the machine, they need to double check it, and they didn't do it. Or have you eaten normally today? Well, I didn't take my medicine because I knew I was going to Cheesecake Factory. Well, that may be why I'm still seeing you, but if you don't eat that cheesecake, can I have it? You know, those things. Have you had any illnesses, usually amount of activity or stress? That can definitely affect your sugar. And depends on how you are, it could make it up, worse, down, better, or not. So they need to keep that in mind. Your secondary assessment is going to be ongoing, continuous. Anytime, now you don't have to check your patient's sugar every 5 and 10 minutes. So y'all remember that. But if you do a treatment, a couple of minutes afterwards, you need to check their sugar. So if you give oral glucose to your patient as a basic, and within 10 minutes of giving it, 15 minutes at the max, you're going to want to check that. Now, I'm not saying that you got to check it repetitively after that 15 minutes, but you need to know, was your treatment good or was your treatment not successful? Did it not make your sugar go up or down, however you were trying to do? So that's important to document that. So that's why we say reassess them. Some vital signs. Oh man, you're gonna notice right here in your hypo and hyper. Hypo is saying their respirations are normal to rapid. Hyper is respirations may be deep and rapid. So you may have a weak pulse in one. Is because in hypo there's no more energy. They ain't got none. Their tank is running on empty, and the body is saying, little engine that could is trying, but it ain't functioning. So that's the reason why all right here on the screen that y'all gonna see that, because pale, cool, calm, and calamity, low blood pressure. Well, they ain't got no more energy to make the body function. This one down here is blah, 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 blah. So that's why you're seeing so much. The pulse may be rapid and the respirations may be rapid. They're deep. They're trying to use those muscles, trying to burn that off because there's plenty there. So those initially is going to be a telltale that what you need to look for. Look for these. If you see those, suspect it, but still get your sugar. Check that sugar before you make a false impression and go with your gut that your gut's wrong. Portable glucose monitor, they are wrong. Sometimes they do fail. We do know that, but we need to make sure that they are working properly. Know the upper and lower ranges. We are required offshore. We test it weekly. I don't know how some of these ambulance services do, but I can speak for mine. I have asked my local service, do we have the abilities to check them in the field prior to our shift? And they kind of look at me like I don't know what I'm talking about. But you do need to check these machines. You do need to know what the manual also says, what it's good for, what's your top number. If it says high, what it's over, and if there's the low numbers, if it's not reading anything, it may be because they're past the market value of that machine. So it may not read anything lower than 10. So sometimes that's important. Most EMS providers don't really care, but it can really help you on patient care. Your reassessment continuously. We're going to continue to look for hypoglycemia, consciousness, can swallow. That's a big one. Just, hey, can you swallow for me? Because if they can swallow and they're sluggish to talk, you can do non-invasive stuff like oral glucose or drink some water, some Gatorade, a little bit of extra spoon of sugar in there. And if they can non-invasively take care of themselves. If for some odd reason they can't do any of that, you're going to have to hire a provider of care. Where it says right there, administer high concentrated sugar gel. If your protocol allows it for a basic, that's cool. If not, then you don't know. And then provide rapid transport, because at some point you can't do it no more. You got to have some help. 2 seconds, y'all. So once you get provided higher level of care, you got to transport them to somebody else that can help them, because you like their sugar, it's tapped out. Now you need to tag team it and get some extra help in there. Hypoglycemia. All right, so for unconscious hypoglycemic patients, for patients with a risk of aspiration, intravenous IV glucose or IM or intranasally glucon is needed. I've never done that, so I've never given it nasally. Before we go any further, make sure once you go higher than a basic, that it's what your protocols say, require, ask. But that right there says beyond EMT competencies. You can't do that. So just want to let you know what to do. If in doubt whether the patient has symptomatic hypoglycemia or hyperglycemia, most protocols will err on the side of giving glucose. When in doubt, consult med control. If you need some help, considerations, you need an extra support, you need to phone a friend. Phone a friend and call and ask for some help. Hey, bro, this is the EMT Basic Chris Wally on Zebco 457, and I need some help. We in the middle of nowhere, and this is what this machine's saying, but should I give it or should I not? And they'll tell you. They'll ask a couple of questions. They may say, yeah, it's not really going to hurt them, but go ahead and transport them here when you give it. Let me know what time you get it and how far you out. Okay. Ta-da. Helped me out. If you're unable to test the blood glucose levels, perform a thorough assessment and contact hospital to help sort out the signs and symptoms. Every service that I know now has that. They're not just they're cheap. They're just as cheap to buy that it is a temporal thermometer. So if a service around here doesn't have it, you may talk to them and be like, hey, what can I do to help you pay for that? Because it's too cheap to not have it. So reassessment, communication, and documentations. You want to keep that. Document everything. Document, and document some more. Sometimes your initial reports will be way too long when you realize it, and then some of the later ones won't be long enough. Because later part of your careers, your reports is just suck. I will tell you that. I've seen some 30-year medics that write excellent reports just because of who they are. And then I've seen a 5-year paramedic that you would expect to have a great one sucks because they just cut corners. But just remember when you cut a corner that you're the one that's going to have to go to court, not your partners. So you're the one that provided the care. Your report's the one that's the most important. So document, and write it. If you have questions about reports, I think there's a section in here for us to do reporting. I'll give everybody a scenario. Well, probably everybody be on the same one, and you'll have to turn in um, a report, and that's the way I'm gonna give y'all credit for that night if we touch that. But I will tell you, there's another night that we have open for a discussion that I am gonna say that that's going to be part of it. So I want to help you with your reports, but that's gonna only be where you'll get credit for that class. That's the way I can demand y'all to do something. Got you on that one. Y'all skipped the chapter, Mickey. Was that for later, or did they who skipped that chapter, Mickey?
We originally skipped it because we're
Or
all
was
in
it me?
different states. Now we're all in different states, so we all have different protocols and different ways of reporting.
No, Victoria.
I think it was Rob.
Mickey. Oh, now we know who to point fingers at. All right. Well, I'll fix that. I'll get up with him and see what we need to do because I'll call him out on it. And there was probably a good reason. I just didn't know the method to his madness. All right. So if nobody knows, seen, have messed with anything like that, that's your oral glucose. Comes in a little tube. There's 3 types of oral glucose. You have your rapid dissolving gel, the large chewable tablets, and the liquid form. Every service that I've ever seen across the ARES use this because it can be thrown in a bag, forgotten about, and it expires like every 5 years. So heat doesn't really bother it. I mean, that's what you see a lot of the times. Some of the contraindications, inability to swallow or they're unconscious. Yeah, that's a really big one. A really big one. Always wear gloves before putting anything in a patient's mouth. One is don't ever put something on your finger to put in somebody's mouth. But I don't want your spit on me, nor do you want your spit on me. So let's just think about that. Follow your local protocols for glucose administration. 99.9% of the time, they'll tell you to put it between the teeth and the cheek and let it just absorb that way. If they swallow some, it's okay, but the residuals can soak through the body and the gum area. I have actually filled somebody from rear molar all the way around to the other rear molar and just let it sit there. And they were talking to me. It was just super sluggish, and I was like, don't swallow for like the first 3 minutes. It was kind of funny, and I didn't mean it to be funny, but it absorbed in their skin a whole lot faster than them swallowing it. Reassess frequently, provide transport. Blah, blah, blah. If they start to deteriorate, you want to try to transport or call for ALS provider early. Obviously, we know why, because the oral glucose was not working. All right, seizures are considered to be serious parts of hypoglycemia. So anytime that you see them, and a seizure period is very important to pay attention to. Some possible causes are infections, poisoning, hypoglycemia, trauma, decreased level of oxygen, um, idiopathic, unknown cause, or fever of undiagnosed epilepsy in children. Seizures may indicate an underlying condition. Ensure that the airway is clear. Pace patient on the side. But nothing goes in the mouth besides what's already in their mouth. Have suctioning, just in case you need it. That's fine. Provide oxygen and artificial ventilations. If the patient is cyanotic or appears to be breathing inadequately, provide oxygen and artificial ventilations. And you can also bag this patient if that's needed. If you just feel that they're not breathing properly, it's your call to just go ahead and just bag them. It is more consuming of an individual for yourself as a provider to bag someone versus putting them on a non-rebreather, because now they're requiring your 100% attention. Anytime that you want them to breathe correctly, you got to bag them. So keep that thought too. Altered mental status may be cause of other conditions. Poison, head trauma, postictal state, or decreased brain perfusion may be caused by diabetes complications. Use the mnemonic AEIOU tips. Does anybody know what AEIOU tips means? Anybody? Does anybody know what the AEIOU tips means? So seizures can be caused by multiple things. I always say, no matter what, check a sugar, and check another sugar. Now y'all see why. Because if they're seasoned, there's a reason why that we just don't know. Postictal state can alcohol and insulin. Yep. Postictal state can last 5 to 10 minutes. Could be a little bit longer, depending upon the time that you got there past the last seizure. It's always important to ask family, bystander, or whatever else, how long do you think that they seize for? It's very important for you to know how long they've seized and how many seizures did they have. If they witnessed one or two, that's fine. That's cool, but you need to know how long they've seized and how long they have been stopped seizing. Always, always make sure the airway is clear. Be prepared to provide artificial ventilations and suction if patient vomits. Provide prompt transport. Misdiagnosis of neurologic dysfunctions. Occasionally, patients with diabetic emergencies are thought to be intoxicated. I think we've said this like 15 times. We know to any time that you get that call for first aid, go to assist PD, or you go out to a scene where they've got somebody detained, might I say, and they ask you to check them out, just poke their sugar. Now get their consent, but check their sugar. And if you realize, hey, this person might Victoria, I don't know if you can post a picture in here for AEIU tips, but you can try if you can. I don't know if you can post it in there. Oh, all right. So um, check those patients out. Just go ahead and do a full assessment on them so that you're more comfortable when you write this report, so you know that you've done that patient a good way. So a patient can be confined. We said that already. Look for emergency medical ID, bracelet, necklace, or card. I don't know what the med card is. We don't see those anymore. That's kind of the older stages. Perform CVG if your protocol allows you. Diabetes and alcoholism can coexist in a patient. So just because they're drunk can also mean they're diabetic. My wife's uncle, many moons ago, shot himself in the face with a 12-gauge shotgun. He's still functioning as an adult in this world, but he has a feeding tube, and I mean it's crazy. This man is a massive diabetic. I have literally seen him with my own eyes take a 12-pack of beer, put it in his feeding tube, and that's the way he drinks because he can't do it any other way. And then he'll take a diabetic shot on top of that. I took care of him when he just attempted to end his life, and it didn't work. And I got stuck with him that day. And that's not how I met my wife, but kind of small world in our area. Um, so just because they are an alcoholic doesn't mean that they're not a diabetic. So treat them two together. Uh, oh yeah, Mac, it was not pretty. Matter of fact, my wife's deer that she killed this end of last year, same barn that I skinned the deer in, kind of looked the same way. That kind of gives you an idea. Um, so some things relationship to airway management is very important because I like my patients to breathe on their own. Means I ain't gotta do nothing for them. I'm not lazy. I will overly do for a patient, but if I ain't gotta do something because they can maintain their own airway, hallelujah, we're moving on. Vomit and tongue may obstruct the airway. You may have to use suction to get it out of the way. Or you can turn them on their side, but eventually you're still going to have to clean the vomit up, so be careful. Place patient in a lateral recumbent position, which we know that could be left. Left is always the best. Malice, AEIU tips, alcohol, epilepsy, insulin, opiates, uremia, trauma, infection, poisoning, and shock. Huh. All right. See, I knew I wanted to learn something tonight. And look at there. I just learned it, Bailey. Thank you. I appreciate that. See, Victoria, she took time to type it in there. So we have three disorders that can create pre-hospital emergencies. They're right here that we're going to talk about. And the hematologic emergencies is all blood-related injuries. So sickle cell, hemophilia A, and thrombophilia. Sorry, it was just a lot more than a pic. Oh, sure. Hey, she got you. Don't worry about it. She's on it. So talk about this one. Blood is made of four components: erythrocytes, leukocytes, platelets, and plasma. Each of the components of the blood serves a purpose in maintaining the body's homeostatic balance. Transports oxygen and carbon dioxide in and out of the tissues. We know it cleans the oxygen. We know it cleans the blood because we've talked about that. So we know that that's important. Red blood cells, RBCs, are erythrocytes. I'm gonna say that again. Red blood cells, or erythrocytes, contain hemoglobin, which carries oxygen to the tissues. That's a lot. White blood cells, or leukocytes, make up 0.1% to 2.2% of a person's blood volume. That that doesn't sound like a lot, but when you look at the entire body, that's a pretty good number. I'm gonna read that again. So white blood cells make up zero point 0.1 to zero point 0.2 of a person's blood cell volume, collect dead cells and provide for their correct disposal, and they respond to infections. Let's see. They help do form clots. That's also very important. They assist. Plasma serves as the transportation medium for blood components, proteins, and other minerals. That's another reason why we want to use lactated ringer versus normal saline, because they have the plasma-like makeup in LR that blood does. It's not, you don't get plasma out of LR, but it's the thickness that's what we're looking for, is to help fill that void, and that's what LR does. It's expensive, so use caution when you use it. Um, Sickle cell. So I can tell you, sickle cell crisis is not something to just brush off. It is a very painful, um, out of the blue, just debilitating disease. I know several people that function with it. I have taken care of many people, but it's nothing to just do away with. Majority of the people that get sickle cell are people from African, Caribbean, and South African descent. African Americans are predominantly in our area that get it, and it is very. I haven't seen it a whole lot, but it is very predominant. People with sickle cell disease have mishappening RBCs that lead to dysfunction in oxygen bonding and unintentional clot formation. So they take medicines to help keep the clots. Uh, they are present but less common in people from the middle and eastern. Where did I just go? Mediterranean or Eastern Europe people. All newborns in the United States are tested for sickle cell disease shortly after the birth. So that's the reason why a lot of the blood from the umbilical cord is important, because they draw it out and they test them for all sorts of issues. Whoops, lost my notes. Clots may result in a blockage known as a vaso-occlusive crisis and can result in hypoxia, substantial pain, and organ damage. That's why I'm saying that it's super, super important to pay attention to these people, because all the pain and the hypoxia, you have a treatment for that on your truck, and it's called oxygen. Hey guys, I got a phone call coming in real quick. Can you give me just a quick 5 minutes? Give me 5 minutes to get this phone call. I'll be right back. All right, sorry about that. Um, so again, back to the hypoxia. We know we have the proper equipment on the truck to fix that. So fix it. Pain, and if you know you're going to a sickle cell crisis, you should request for ALS services, because they're going to need pain medications. Sometimes I don't. The last few that I had were pain sensitive to certain medications, and I don't know if that's just something over time, or they may just say I like fentanyl better than morphine. So, but again, that's something that we can help them with. is to ease some of the pain off. So let's recognize that early. Sickle cells, they do have a short span of life, resulting in more cellular waste products in the bloodstream and contributing to sludging of the blood. Maintaining hydration is important. So if you know that they're sickle cell, ask them, "Hey, bro, when's the last time you drank something? You drinking like you're supposed to?" Um, Complications associated with sickle cell is anemia, gallstones, jaundice, splenic dysfunction. Gallstones are probably your most common, and anemia are is your biggest ones to see. I think jaundice is more of the younger kids. I haven't seen a whole lot of issues in my career of the older ones, the older adults having jaundice issues, but they could if they start to have splenic dysfunction. There's a few other things that you may have to worry about is the lack of blood in their bodies. So if it's a traumatic event and you know they are sickle cell patients, they may not have as much blood in their body. So that's something you're going to have to think of in the back of your head when you go to treat them. Some of the pathophysiology, sickle cells is a vascular occlusion with ischemia, acute chest syndrome, hypoxia, dyspnea, chest discomfort, and fever is the acute syndrome. Stroke, joint necrosis, specifically the head of the femur of the humerus, so it's going to affect their legs really bad. Their pain crisis, and I don't mean just like I don't want to say it that way. It's not like when they go into a crisis, it's like they've been involved in a multi-traumatic event that everything on them hurts. So that's what I kind of give you an idea how painful it's going to be is because everything on them hurts. So if we can help them, let's fix it. Acute and chronic organ dysfunction or failure that could be in some of the later cases that we're going to see. Uh, Increased risk of infection, so they may always be sick. They may be always having white blood cell count problems or in and out of hospitals a lot because they're trying to treat and fix that on the fly. Um, so many of these complications are very painful, potential life-threatening. The patient is also more susceptible to infections, like we just said. Um, Clotting disorder, hemophilia, is super, super, super rare. It says right there, only in about 20,000 Americans have this disorder. Hemophilia A affects mostly males, so that may be something to consider. Um, Clotting disorders. People with hemophilia A have a decreased ability to create a clot after an injury, which can be life-threatening. Patients with hemophilia A typically have intravenous factor 4, was that 5, 6, 7, 8 replacement infusions, which help with the blood clotting, either close or handy with them. Clotting disorders, commonly complications, long-term joint problems that may require a joint replacement, bleeding in the brain. They may have a lot of hemorrhaging and thrombosis due to some of the treatments. Sorry, I'm giggling at my kids at the same time. So, thrombolia is a disorder in the body's ability to maintain the smooth flow of blood through the venous and artery system. The concentration of particular elements in the blood creates clogging or blockage issues. So they may block up, they may turn around and create a clot, or it may not be, it's just going to, because the area may be thinned and they can't thin the blood out to pass through an area, so it's going to start backing up. Thrombolia is a generally term for many, many different conditions that result in blood clotting. It's usually normally the inherited, so it's inherited. Some medications or other factors, and patients with cancer may get this issue. Clots can spontaneously develop in the blood of the patient. I have never treated any of these, so I can't really give you any signs or things to look out for. I just don't know. I'm only telling you what I'm able to pull off my notes and what I've looked up. Clotting disorders. We talk about DVTs. We all know what those are. You can see them in the legs and in them It's not the spidery veins, but you get the spidery veins. You can also get DVTs from that. It's a common medical problem in sedentary patients and patients who have had a recent injury or surgery. That's why you get those pretty little leg stockings on when after you've had a surgery and you can't get up and move around. You may encounter several methods to prevent blood clotting. They may be on a blood thinner. You're going to see them on compression socks. I can't make fun of compression socks no more because, like, when I fly a lot, back and forth across the world when I used to fly a lot, I wore my compression socks. They very helpful. So I can't make fun of that. And the mechanical devices, and that's what we're talking about the socks and all that area. So that one's there. Sometimes they'll have them at home, and you'll see those there. So if they have them at home, that you need to try to see how long that they can be off of those, and you may have to. So if that's something that they can't come off of them for a hot minute, maybe you're over an hour, 2 hours of from the facility of a transport, you may try to have to just figure out how to put them in the back of your truck like everything else, because everything goes in the ambulance that they pack and load for you to take too. Some DVTs. So a recent history of joint replacement who's complaining of leg swelling, travelers, truck drivers, long distance bus drivers, bedridden nursing home patients. Maybe they should have these compression socks on to some of those. Unfortunately, we can always see your travelers. I fill in there, truck and long distance drivers. Unfortunately, a lot of these are heavier, a little bit of obesity, and that's because they sit around a lot. They drive hundreds of miles, and they don't really do anything in their time. And that's the reason why sometimes they don't have the best of diets either. So all of these can cause DVTs, but there's several things you can do to prevent those. Bedridden patients in a nursing home, there's nothing you can really do unless they're treated correctly, have the leg things on, they're turned often. PT comes in there and they do some leg workouts, massages on them. That will help over time. Some of the treatments, we know that they're going to be on clotting medication. Sometimes they'll put them on there for up to 3 months afterwards. Self-administrated sub-Q injections or oral meds are also used. You may get them in the stomach, depends on where you get the shots at, but DVTs are pretty serious because they can stop your heart in a second. Patients prescribed medications to treat a DVT are at an increased risk of bleeding, complications, and the gastrointestinal bleeding and minor trauma is more likely to produce several internal or external hemorrhaging. A clot from the DVT can travel from the patient's lower extremity to the lung, causing a pulmonary embolism. So that's super, super important. We want to be careful for that. Pulmonary emboli can cause chest pain, difficulty breathing, or sudden cardiac arrest. Can anybody tell me why that's the case? I know y'all are all Googling it, so it's okay. Plus, it's giving me a time to put something in my belly. Victoria, that's right. Ultimately, in the end, you don't have to know the pathophysiology of it. You don't have to know the right terms. But ultimately, it's a clot that sends it and stops everything up. It backs it up. Then you die, and it can be very sudden. Obviously, y'all know what time it is because we're getting into the scene size up and all that. Let's take 10 minutes before we get into this. I need to get out and do a few things out real quick. Take 10 minutes and meet y'all back here at 8 p.m. Anybody got any questions real quick? Concerns, problems, If you're gonna fuss, make sure you got an answer to fuss about it, or PM me on the side. All right, see y'all in 10 minutes. All right, folks. I know y'all are, I swear these 10 minutes go up quicker than anything else. Um, Going back over scene safety. So the reason why I say in here to wear gloves is because what we want to do is to keep them from getting any sort of infection. The reason why I'm not saying don't wear gloves. But there's sometimes you may take a little bit longer to put your gloves on versus the other because you may know these patients in your area because they are sickle cell and you will transport them pretty regularly. But the gloves mainly are for preventing any infections upon the patients. I'm not real sure why they're saying eye protection at a minimum, because the patients they don't there should not be an opened wound and you're going to them for sickle cell issue and squirting at you. But I have a pair of safety glasses that I like to wear when I work on the streets. It's just because I'm a nerd, but I mean it's not a bad idea if that's something you consider. So your primary assessment, is the patient in pain of an African American Mediterranean descent? I'm not sure why that really matters if they're telling you it's sickle cell, but it is important. If yes, you may have an unknown. That's what it is. If they are say yes, and they are an African American or Mediterranean descent, it could be from an undiagnosed of sickle cell. Sorry, didn't read ahead. Perform a cervical spine immobilization if you have to for a general impression. Is your impression current? Is it up to date? Or are you just lazy and be like, oh, I've already been to Fred 500 times. Here's what he's going to say. He's going to complain. Things change. Let's not get into a routine. Is the patient apneic or are they irritable? That may tell you if they're suffering from oxygen deficiency or any other issues. Determine level of consciousness. Can they answer your questions? Are they able to moan from pain or are they unresponsive? Assess the airway. My thing is I like to walk in the room like, hey, how's everybody doing? What you doing? And I look at them. If they can look at me and answer me, I'm assessing their alertness, I'm assessing their responsiveness, and I'm also assessing their breathing. So the only thing I didn't really check was their circulation, but if they do in those three things, I'm pretty sure those three are checks in the boxes. Provide high flow O2 if needed. We all talked about that already. Patients experiencing sickle cell crisis may have increased respirations or exhibit signs of pneumonia. For patients with breathing difficulty, open the airway, insert an adjunct if needed, and administer oxygen assisted ventilations. We know that. We've talked about that a couple of hundreds of times. But the issue is, I have to tell you again. Forget it. Assess the patient's circulatory status. Sickle cell crisis patients will have increased heart rate to force sickled cells through the smaller blood vessels. That's why it hurts so bad, is because they're forcing those thick, hard blood vessels. The I'm sorry. It's the forcing the blood cells through the blood vessels because they're so hard. For suspected hemophilia patients, be on alert for signs of pallor, weak pulses, some hypotension. If you have any types of bleeding, but they don't know why, they just started bleeding, that is something that you need to note and be on the lookout for. Nosebleeds, spontaneous nosebleeds are part of it. Any type of bloody sputum, that's something that I don't want on me. Make sure that it's you use protected. Don't need it, don't want it. It's not happening. That's another reason why I wear glasses because I don't like stuff on I don't like your secretions coming near me. Don't want it. If you happen to ask them, hey, anybody chance if you noticed any types of blood or uh, discoloration of your urine or your poo. And your only reason asking that, not that you really care, other than besides medical wise, is that'll give you signs where they have potentially have a upper or lower GI. Being alert for signs of hypoxia, uh, which is due to blood loss. We know that. We talked about that in other chapters. Transport. Are we gonna stay and play? Because there's really not much we can do for these sickle cell crisis patients. Y'all know that. So we need to get them to the ED, get them taken care of. So investigate chief complaint, obtain of history, what's going on, who can I talk to who can tell me most about this patient since they're in so much pain. And they could be in so much pain that they don't want to talk to you because it just, everything on them, like their hair on their eyelashes hurts. That's how bad it is. There's swelling to the fingers and toes from, and sickle cells can also cause priapism or jaundice. I personally have not sound off found priapism in sickle cells. I'm not saying I look for it, but if it is there, we need to address that. Um, I know, Mac. I know. I'm with you too. I do the same thing, bro. All right. You should ask the following questions. Is the pain isolated to a single location or felt through the body? Because that tells you about the area of proximity that the sickle cell is affecting. Is the patient having visual disturbances? Are they going blind? Are they're in and out? Or can they say, oh, well, things just went blurry all of a sudden? Is the patient experiencing chest pain and shortness of breath? Well, I can fix one of those, but I can't fix the chest pain. So if they say yes to chest pain, I'm automatically going to the cardiac side. I'll talk about sickle cell later. We want to talk about your sample history. We know those, and ask the I really like to ask is, when was your last crisis and how they fix it? So that answers majority of those. If they've ever had this before, they're gonna know the process. They just really need you as an Uber to get them there. And most of the time, they do want to go by ambulance, and don't be the butthole that says, "Well, you got 17 cars out there. We're kind of loaded right now." Because we can do pain management as an ALS provider if the ALS shows up, and they should know that. So that's the reason why we need to take care of them as best as we can. Secondary assessments, we know 5 to 10 minutes, critical, non-critical. Vital signs, we talked about that earlier. CBGs, reassess that CBG if you used a tool, some oral glucose, check their breathing. If you're a good hour away from the hospital, you don't have to check their blood pressure from the initial time versus 10 minutes. Just check it about halfway there, maybe 30 minutes out before the hospital, and you're trying to give a report, something to give that's the most current blood pressure zone. Um, it's a very good practice to get two blood pressures no matter what. Your reassessments, check your interventions. If you gave them that oral glucose and you're like, oh crap, I'm doing everything else and I forgot to recheck the blood sugar, be like, hey, bro, I got to poke your finger again. My bad. Let's use that other finger. Let's make both fingers sore. Hospital care, we know that they need to be there for sickle cell. Some of the things that they'll get is analgesics, penicillin, IV fluids, blood transfusions. So those are their big treatments that they get. Let's see, administer supplemental oxygen if you have to. And all of this, we want to make sure we document. You will see them get IV fluids for the sickle cell crisis due to dehydration, because we told you that they can't drink enough. They dumping it. They got to go somewhere, so you know that eventually they will get dehydrated. All right, so hospital care for hemophilia, IV therapy, which y'all can't do, transfusion of plasma, which I can't do. So guess what that means? We gonna take them to the hospital right there. Hospital. Done. Got to take them there. We're the Uber. So, as happy as y'all are, mainly supportive care. I always, another thing is to provide comfort care, man, and that's always in my report. Provided comfort care all the way to the hospital, because maybe just talking to them, putting your hand on them and saying, listen, we're gonna do the best thing for you. We're gonna get you to the hospital, and just reassuring them that everything's gonna be okay at some point is the best time. Um, it kind of also, when I write my report, it kind of brings me back to reality, is saying that I need to remember to not just be a provider, but to be a human and to be nice to people that's in the back of the ambulance, because there's a crisis upon them that we need to fix. Taking care of them, and then at the same time is taking care of us. If we need sometimes patients can provide the best care for us also. Kind little words like thank you so much for your help. You've been super sweet. You and your partner are awesome. Y'all been the nicest group to come out here. So just being a human to people is the best part. That's awesome. Um, and I know, Mac, I know you're upset. I really know you're upset, Mac, and I'm so sorry. I can probably find something else to talk about if that's what you need, Mac, so we can make sure you're awake and you got this. But folks, I mean, y'all provided some really good feedback. You gave some good information. I just think that this has been a good class. Y'all chatted a pretty good bit in here, and I really do appreciate y'all's input back and forth. So I'm gonna give y'all kind of an early night, and I was just realized that I hadn't fed my kids, and it's 10 after 8, and I was sent a text message saying, "Dad, I'm hungry." So I gotta take care of a kid, just like everybody else does. Here's your code for the night: 14TF23X. I will save 14 Tango Foxtrot 23X. X-ray. Anybody else have any questions, problems, concerns? Let's talk about it, air it out. If not, I know the numbers are fixing to start dropping pretty drastic now that you'll have the code. Um, Thursday night, it is. See y'all on Thursday. Deuces out, everybody. Have a good night. Oh, thank you, Victoria. I'm so see that's the reason why I got friends. People remind me. I can't type it. I don't know why. Can you type that, Victoria, please? It won't let me. Thanks, Mac. Appreciate y'all. Y'all have a great night too. Y'all holler at me if y'all need some help.